Partial nephrectomy for renal cell carcinoma. Kidney sparing surgery for renal tumor was first described by Zerny in 1890. However, significant morbidity limited to its use for the next half century. Vermeulen revisited the concept for local excision with a margin of normal parenchyma for encapsulated and peripherally located renal tumor in 1950. The use of partial nephrectomy for RCC has subsequently been encouraged by increased experience with vascular surgery, absence in renal imaging, growing number of incidentally discovered small renal masses, greater appreciation of the deleterious effect of CKD, introduction of minimally invasive techniques, and encouraging long-term survival in patients undergoing this form of treatment during the last 50 years. Kidney sparing surgery entails complete local excision of the tumor while leaving the largest possible amount of normal functioning parenchyma in the involved kidney. Initially described for patients with the absolute indication for kidney sparing surgery or for the elective indication of a small renal tumor in the setting of a normal contralated kidney, partial nephrectomy is now strongly considered whenever preservation of the renal function is potentially important. Common indications include conditions that pose a threat to future renal function such as hypertension, diabetes, peripheral or coronary artery disease, nephrolithiasis, patients with the baseline CKD and abnormal contralateral kidney, and those with the multifocal familial RCC. Partial nephrectomy is considered feasible for majority of the localized RCC less than 5 cm and tumor more than or equal to 7 cm by those with expertise with kidney sparing surgery. Particularly for those with an absolute indication for nephron sparing surgery, partial nephrectomy can even be performed for tumors that deeply invest the renal vascular structure or with limited venous thrombus, but such procedures clearly carry higher perioperative morbidity. Local recurrence rate after partial nephrectomy for imperative indications have averaged 3 to 5% or higher in historical series, and decision to perform partial nephrectomy in such circumstances should be individualized, weighing the potential increased technical and oncological risk of such an operation with the renal function consequences of radical nephrectomy. Partial nephrectomy constitutively leads to improved functional outcome, and when compared to radical nephrectomy, even with complicated situation, temporary permanent renal replacement therapy is necessary in less than 5% of the patient undergoing partial nephrectomy in a solitary kidney, and in rarely needed patients with a functioning contralateral kidney. In fact, the vast majority of the patients will avoid permanent dialysis even following multiple surgeries for multifocal tumors in both kidneys, as long as at least 30% of a well-functioning remnant kidney is preserved. For situation in which partial nephrectomy is deemed impossible, radical nephrectomy with ensuring hemodialysis is sometimes necessary. Although pre-surgical therapy with a tyrosine kinase inhibitor is an alternative approach that has proven successful in downstaging tumor size, allowing for more partial nephrectomy in some patients. For patients with clinical T1 renal mass, local recurrence rate are 1 to 2% after partial nephrectomy and commonly located distant from the initial resection, and this therefore may represent a new primary tumor rather than a recurrence of a excised lesion. Cancer-free survival is achieved in above 90% of the patients. Meta-analysis of a published studies reveals cancer-specific survival of more than 98% for T1A, 90% for T1B, 86% for T2 treated partial nephrectomy, and the contralateral kidney is also at risk for metachronous disease, which also occurs in 1 to 5% of the patient even with contemporary imaging modalities. This provides further rationale to avoid unnecessary radical nephrectomy for tumors amenable to kidney sparing surgery. Goal of partial nephrectomy is resection of the grossly appreciated tumor with negative microscopic surgical margin. This is generally performed with a thin trim of normal parenchyma based on prior literature indicating that margin width is immaterial. Some centers now routinely perform enucleation of the renal tumor along with the pseudocapsular plane with excellent oncological outcome. Although enthusiasm for more widespread use of this approach has been tempered by the somewhat higher recurrence rate among patients with RCC with positive margin and the propensity of some RCC subtypes to invade the pseudocapsule. A novel scoring system SIB score was recently introduced aiming to standardize of tumor resection reporting and is currently being evaluated to assess the best safest partial nephrectomy resection technique. And with the last decade, substantial progress has been made with minimally invasive partial nephrectomy, which is now the most commonly performed procedure for small renal masses. Laparoscopic radical nephrectomy with or without robotic assistance is performed according to the some principles as open partial nephrectomy. Margin status oncological outcome with laparoscopic and open partial nephrectomy appear equivalent in series of these patients with in which patients were selected appropriately for each of this approach. Each to early to immediate intermediate experience with lap partial nephrectomy suggested increased urological complication compared with open. Subsequent experience with a pure laparoscopic partial nephrectomy and more prevalence use of robotic partial nephrectomy have substantially reduced perioperative morbidity. Tumor complexity remains the major predictor of intraoperative postoperative complications. Regardless of the surgical approach, open partial nephrectomy should be considered for particularly challenging situation.